actually our neuroscience clinical pharmacist at Wake Forest Baptist. How long have you been with us?
Just over a year.
Oh, just over a year?
Yeah.
Okay, all right. And maybe you noticed already, but she is expecting her first child in February. Congratulations.
Thank you. There's a pregnancy requirement on the speaker. Pregnancy requirement for the speakers today.
Right, it is. You have to be less than 35 and have either young children or be expecting it.
Yeah.
All right, so anyway, Dr. Kline actually did her doctoral pharmaceutical degree from the University of Maryland. You grew up in Maryland, right? Because I saw where you said you kind of drifted down south to Winston-Salem. So we were very fortunate that you did that. She actually completed her PGY1 in pharmacy practice and her PGY2 in critical care from Charleston Medical Center in Charleston, West Virginia. So with that, I won't take any more of your time because we want to hear all about.
We have a lot to talk about today.
We do. So it was interesting that Dr. Goldman actually mentioned.
Set me up. Dr. Goldman prepared me.
He set you up for that one, right?
Yes.
So anyway, thank you very much for being with us this afternoon.
No problem. I'm happy to be here, guys. It's been a great day. I hope y'all are enjoying it. I do have some notes here to keep myself off of my tangents and conserving my breaths. So without further ado, we're going to focus on medication management really across the various transitional care settings. And I have no conflict of interest or financial relationships to disclose. And by the end of this, my hope is that you'll be a little bit more comfortable combining evidence with practical and pharmacokinetic considerations for that medication use across the various care settings. I'm hoping to make this applicable to a very wide range population, and we follow the stroke patient through their various care settings. We'll also be able to utilize updated evidence to optimize secondary stroke prevention. For risk factors, I'm going to focus pretty heavy on hypertension and hyperlipidemia. And then we'll briefly just identify some appropriate strategies for antiplatelet and anticoagulant therapies. So in defining the continuum of care, we definitely see patients in this variety of care settings, and the scope and focus of each of those settings is really going to differ for their goals as well as their medication selection and the timeline at which they would be expected to be within that setting. So the hyperacute or the pre-hospital emergency department and ICU time, their focus is of course to get them to, off of continuous infusions, off of costly resources, and get them to a more stable setting. That acute setting would be the more inpatient hospital floor or general ward type of transition. And then from then on, we're going to go from the acute setting to hospital discharge, where we're focusing on things that keep them safe, a safe disposition, the right location, appropriate resources, and ensuring medication compliance. Then that initial follow-up is going to be married very closely together to that hospital discharge with the hopes of bridging the gap between hospital discharge and that long-term outpatient chronic management. So I do have some audience response in here. You can play along, and then I'm also going to, for the sake of time, go through some of my answers. But I wanted to see, by show of hands, true or false, nicardipine infusion is the drug of choice for initial blood pressure management of the acute stroke patient. So who says true? No takers? Okay, who says false? Okay, everyone's saying false. Because it's a trick question, right? So while it's not the wrong answer, it's often the initial management for many patients. But I did want to remind us of a few things when we're thinking about the drug of choice. So evidence or literature to support its use, any shortages, inventory availability, and cost considerations, very logistic considerations, and then of course appropriate patient selection. So we're going to be speaking in a lot of gray areas today, and I don't have very robust evidence or answers, unfortunately, but that's really what we're up against. And so I wanted to kind of reason through some decisions and common sense practicalities for us. So first, identifying the overarching goals of blood pressure management in the hyperacute setting. The 2018 guidelines for the acute ischemic stroke would require that we monitor blood pressure or maintain blood pressure at less than 185 or 110 to make them eligible for TPA. and then adequately maintain them for 24 hours after that TPA infusion to 180 over 105. If they do not receive TPA, then it would be less than 220 over 120. And conversely, for hemorrhagic strokes, the 2015 ICH guidelines would stratify that for patients that present with a systolic of 150 to 220, that they would be lowered to less than 140, and that it, quote, may be reasonable. For those that present with a systolic greater than 220, it's noted that aggressive reduction should occur with likely a continuous infusion. So pretty vague. And then following along with that, when taking a closer look at evidence, it's prudent to note that guideline review has resulted in merely a Class 2 level of evidence C statement that alludes to the lack of available data to guide selection of blood pressure medications. But these are, quote, reasonable options. And so we find things like labetalol, nicardipine, clofidipine, hydralazine, or enalaprilat, whether they be IV, bolus dosing, and continuous infusions. And additionally, as the patient transitions out of that initial presentation and critical management to receive interventions, it's still uncertain, quoted uncertain, as to whether starting or restarting blood pressure meds within the 48 to 72 hours has any direct benefit on true clinical outcome. In practice, we do sometimes delay resumption of chronic medications until the body has adjusted from that acute injury, that the autoregulation has been restored, and that we get a better idea of separating the acute hypertension from the event versus some sort of chronic elevation that would need to be addressed. But we're still unfortunately left with questions like, when do we lower the blood pressure and how do we do it? Perhaps the more concerning question at hand, though, is why. Why is it 2019 and we still debate something that we think should be simple, but it's in fact not simple at all? So likely, this is due to our struggle to balance available evidence, pathophysiology, and theory. On the side of evidence, high blood pressure has been associated with poor outcomes in the ischemic stroke patient, whether that is late death, dependency, or early recurrence. But there's no strong quality evidence that acute hypertension itself has negative outcomes in the very acute phase infarct, which is why we see some soft language in our literature. There are theoretical benefits to reducing blood pressure in the acute setting, such as reduced edema, like we heard about today, decreased risk of hemorrhagic transformation, that ischemia transforming into blood formation, decreasing further vascular damage. However, the same also goes for hemorrhagic strokes. There's definitely a clear relationship of chronic hypertension and ICH, but the evidence suggests that that blood pressure may be associated with hematoma expansion and poor functional outcomes. Bad things, of course, but there's really been no direct causal relationship that ties that together in evidence. It's more so that we kind of marry that together in an assumption that's likely valid because it makes sense. On the side of pathophysiology, it has been shown that the hyperacute phase, there is definitely a dysfunction of the brain's natural ability to regulate the available blood flow, and that would be in support of blood pressure lowering. Conversely, though, there's a concern not to lower the blood pressure too much at risk of not perfusing and not giving adequate perfusion to those already damaged tissues. So then we're left to concoct our wish list of the perfect blood pressure medicine for the acute stroke patient. And an optimal agent would not impair cerebral autoregulation, not increase ICP, not decrease cerebral perfusion, and most importantly, perhaps, that it's easily titratable and it has a short half-life. Now, I could bring you through all of the theory by class, and this is a summary of a lot of the evidence that I've dug through, but unfortunately, these several small studies that have attempted to characterize the impact of these agents on things like cerebral blood flow, cardiac output, heart rate and blood pressure variability, and some even neuroprotection with mechanisms left unexplained. There's just a lack of descriptive, well-defined use of particular agents and particular doses in protocolization that leaves us without a means of application to clinical practice. So really, the heart of management in the hyperacute and the acute setting relies heavily on the ease of titration. And so take note, medications such as prazosin, captopril, labetalol, and hydralazine are several options with the fastest onset and half-lives. As you can see, a lot of this is for reference, of course. And they allow for much quicker titration compared to medications such as lisinopril, amlodipine, or thiazides. But conversely, we'll see in later slides that we're going to shift focus whenever the patient becomes less acute and we're transitioning to more preferred therapies. The art of this is not really a science, but again, an art. It's in balancing whether we increase, up titrate, or we're down titrating these medications to meet the goals of the patient at the appropriate care setting that they're in. So that brings us to our first case. This is a true scenario. Patient VS was a 65-year-old female transferred from an outlying facility for an acute ICH. So her past medical history included asthma, COPD, CKD, and hypothyroidism. The patient presented with a blood pressure systolic of 224 over 121, and the pertinent admission medication as far as blood pressure is that the patient was only on lisinopril 40 milligrams daily. It was determined that her hyperacute therapy goal would be a systolic of less than 160, likely a little bit softer than the normal 140 guideline recommendation, secondary to CKD, not wanting to further potentially damage any sort of perfusion that would be still needed. And so this is a very long and complex timeline that I'm going to transition over that's still available on the second slide for you guys. But in a brief description, this is a summary of a very prolonged ICU stay secondary to resistant hypertension and an unfortunate struggle to get that patient off of a continuous infusion. So the patient was initiated on nicardipine, was transitioned to clofidipine, as some patients may respond to one better over another. And of course, I'm leaving out a lot of details here, obviously. We don't see repeat vitals. We don't see any sort of events that maybe have happened. We don't see whether the patient was on hyperosmolar therapies that may impact blood pressure. But the general gist of this is as they've transitioned, I'm showing you what we've started day by day. So at the second day, we start with amlodipine, lisinopril, and hydralazine, 50 milligrams 4 times daily. The evening, which is the second sort of row here, the patient did lose access enterally, so was transitioned for just a very short time to receive IV and alloprolat 1.25 scheduled 4 times daily, and they had only gotten 1 or 2 doses of that. Access had been reestablished for enteral administration the next morning. Patient continued on clofidipine, amlodipine, lisinopril, and then I've bolded the ones that we've increased. So hydralazine as an increase, as well as the initiation of clonidine. Then we come to the next day, amlodipine, increases of lisinopril, still with hydralazine and clonidine. And that was into the 17th and 18th, the first time that we were able to get the patient off of the clofidipine infusion, but you'll see in the evening required it for a short time again. And then on the 19th, we had transitioned lisinopril now up to their home dose at maximum dosing, 40 milligrams a day. And then into the 20th, maintaining off of continuous infusion still, we see the final blood pressure medication regimen as they transition to the floor: amlodipine, lisinopril, hydralazine, clonidine, and newly added prazosin. So I want to open this up for brief discussion, and I'll talk you through it. Do we agree with the hyperacute management of blood pressure for patient VS? Any thoughts going on? Yeah, so that's a great question, was why not use labetalol instead of, you said clofidipine? Yeah, so labetalol, clobidapine, and nicardipine all are options for therapy. It's going to depend on definitely patient vitals. I didn't give you anything about heart rate. Maybe the patient did not tolerate it from a heart rate perspective. And then the other things too are shortages and availability. So I believe right now we're still on a decent shortage of labetalol. But a good question. So the way that I'm sort of tackling this is the initial hyperacute therapy of a continuous infusion. That patient presented with a systolic greater than 220. So absolutely appropriate that we manage with the continuous infusion up front. And then transitioning.
Transition to our home med.
Transition.
Like back to our home meds too quickly.
Transition back to our home medications too quickly?
Yeah.
Okay, yeah, so we started, we're finding this balance that I had just talked about where when do we start it? How do we start it? We started with lisinopril at 10 milligrams, so definitely not at max dosing. It's going to take a little bit longer to take effect comparatively to some of our shorter titrated agents. So while it was an early start, usually earlier actually than we normally see for a patient, probably okay as we started to slowly transition with the addition of those faster titrating medications. So there's a lot of things going on, a lot of moving parts, and you'll see in a very hyperacute setting, oftentimes we'll get these patients onto the floor and say, well, what were they doing on this medication and this medication? And it is very a delicate balancing act of initiating medications that are going to be more preferred in long-term therapy against those shorter acting, very highly titratable drugs to be able to get them off of those continuous infusions. So definitely, I would say overall, I definitely agree with the management of this care. And again, hindsight is 20/20. You don't get to see the very intricate, daily things that are happening. But it does make sense with the up titration of shorter acting medications, along with that gradual titration back to their home lisinopril. So assuming if we move along through this case that they achieved that increasing control of the blood pressure, how would we transition to acute therapy and prepare for discharge? Does anyone think A, discontinue lisinopril? Does anyone think B, discontinue prazosin? Option for sure. C, discontinue clonidine? Okay, a few. And D, discontinue hydralazine. Okay, so there are some things at hand. Definitely looking at compliance. We want to take a look out for 3 times a day, 4 times a day medications. So that leads us into consideration of things we don't want: prazosin, clonidine, hydralazine. Okay, all would be not first-line agents. But in being able to taper those down quickly, whenever you have seen that they're currently at maximum doses, is definitely going to be a struggle whenever they are suddenly removed from the ICU and you're ready to discharge them tomorrow. So the common sense answer that I chose personally would be discontinue prazosin. It just makes logical sense that it was the most recent medication that was added and has been around the shortest amount of time that we can get off first. Clonidine I would definitely want to remove, secondary to the fact that it's simply not a higher tier first-line agent, but that would definitely take a little bit of time, and I wouldn't want to stop at cold turkey as they've been on it for 4 days and they're at very high doses. And then discontinuing hydralazine, again, at maximum dose currently, so I would probably maybe take a day to taper that down. I hope that makes sense. Okay, awesome. So moving on, as we transition this patient from the acute stay and preparation for discharge, we're going to focus more on outpatient and secondary prevention measures. And the latest stroke guidelines for secondary prevention are from 2014, so they are somewhat dated, as I want to give something really new and fresh to you guys every single year whenever we do a talk like this. And they still remain vague. They remind us that less than 140 over 90 is reasonable, less than 130 systolic is appropriate if it's a lacunar stroke, and the choice of drug is still based on pharmacologic properties, mechanism, and patient characteristics. So I wanted to briefly review the most recent hypertension-focused guidelines that are put forth by the Journal of American College of Cardiology. And they are uncomfortably more aggressive, as you can see. The majority of us are probably hypertensive in this room right now, including myself. Normal has now been described as systolic less than 120 over 80. Elevated considered to be 120 to 129. Stage 1 to be 130 to 139, and that would initiate pharmacologic treatment at that time. And stage 2 to be anything greater than 140 over 90. And it is documented that greater than 2 agents may be necessary if they are greater than 20 over 10 millimeters of mercury above their goal. So again, pretty steep. But we're going to see that we're going to get more aggressive as the patient becomes further out from that acute event. We do see more clear delineation of primary agents versus secondary agents. Again, trying to bring some clarity to this topic that is very gray and very broad. Primaries being thiazide therapy, ACEs or ARBs, and calcium channel blockers. There are nuances and things to think about that I've provided mostly for reference within these charts. And secondary agents would include things like other diuretic classes, beta blockers, alpha blockers, and then we see our clonidine and hydralazine from that case. It is important to know that whenever I really think of beta blockers, if the patient does not have a compelling indication for beta blocker therapy, like ischemic heart disease or heart failure, I try not to let them go out on a beta blocker. It's not first-line agent, and oftentimes they're not the most bang for our buck, quote, whenever we're looking at blood pressure lowering. It is also important to try to prefer cardioselective in patients that have any sort of bronchospastic airway diseases. And then the medications that are in these other classes, although they may be used in a hyperacute setting for those that ease of transition, being things like clonidine, hydralazine, we often aim to down titrate these in more chronic management, secondary to just utilizing preferred first-line agents that have better efficacy in terms of blood pressure lowering, as well as some further benefits and some even in mortality. So bringing back to that same patient, they ended up being discharged from the hospital on lisinopril 40 milligrams, amlodipine 10 milligrams, and then you do see that we did start to work on clonidine 0.2 milligrams TID, so we did come down a little bit. Wanted to think about some of the following options. Again, this is not a one-size-fits-all. All of the following would be options for blood pressure regimen, except. So do we think it's A, initiate lisinopril hydrochlorothiazide combo and down titrate clonidine to discontinue?
No, because they have kidney disease.
So it's a good thought. Kidney disease in ACEs or ARBs. So there actually has been studies shown that in CKD of greater than 2 to 3, class 3, I believe, or CKD 1 and 2 with albuminuria, it's actually renally protective to consider ACE inhibitors. So I didn't give you any information about their stages of CKD, but if it was not an acute impairment, I would still be okay with that ACE inhibitor. How about B, initiate furosemide 40 and down titrate clonidine? Anyone? C, initiate spironolactone? Or D, initiate carvedilol? And so we're thinking about which one is the worst one here. Which one do we not want to do? Yeah, we don't want to do carvedilol for a couple different reasons. The patient doesn't have a compelling indication for a beta blocker. And then we also would want to avoid secondary to her asthma COPD history if possible. And then the other thing to note is spironolactone would be a potential option. However, that would be my second to least favorite, secondary to that kidney disease, and would potentially expose them to hyperkalemia risk. All right, so we're going to drift into some hyperlipidemia therapy. I don't know if Dr. Goldman's still in the room, but I was really excited about this slide after all of his statin encouragement. So the 2014 secondary prevention guidelines do mention that for basically almost anyone and everyone, you get a high-intensity statin. You have a stroke, you get a statin, and we want it to be a high intensity for the majority of cases. They look at atherosclerotic origin. So if the patient does have that origin, if their LDL is greater than 100, and they may have other ASCVD, which we're going to talk about what that is, high-intensity statin. If they have atherosclerotic origin, LDL less than 100, and no other ASCVD, you still get a high-intensity statin. And then for patients that have stroke or TIA and other comorbid ASCVD, it's recommended to look at the most recent guideline therapy for determination of that hyperlipidemia treatment. And so in a brief review for reference, again, what high-intensity statins look like, it would be, for reference, atorvastatin 40 milligrams to 80 milligrams, and rosuvastatin 20 to 40 milligrams. The bold versus not bold, I wanted to clue you in. The bold ones are ones that have been supported by randomized controlled trials. All right, so in a lighter sort of audience response, now that we went through that heavy case, the most recent hyperlipidemia guidelines, what do we think? Do they treat with the following principle of treating to an LDL-C target? Do they treat to a statin benefit group? Do they treat to a combination of both? And who's confused? All right, raise the roof. They actually, we're going to find out, they treat to a combination of both. And then in clinical ASCVD, we talk about that a lot, but some people are like, what is that acronym? And oftentimes I have to refer myself back to making sure that I'm looking at what these true comorbidities are. So they encompass all of the following except, is it A, ACS, B, history of MI, C, venous thromboembolism, D, stable or unstable angina, E, coronary revascularization, F, stroke or TIA, or G, PAD. C, good job, guys. Venous thromboembolism. So that's almost more there for us to look back to. And then talking about the newest set of multi-society agreed upon guidelines, actually these are pretty robust, and in putting this together, I kind of learned a few new things myself. But clinical ASCVD automatically buys you a high-intensity statin, and we've talked over and over today about how important they are from an LDL lowering property as well as anti-inflammatory and plaque stabilization properties. But there's a new category that I wanted to bring great attention to, is that there's a very high-risk ASCVD and LDL greater than 70 category that would consider an addition of a non-statin to the statin therapy. And of course, this is just more so guidance of when to expect that measuring of an outcome, but it would be 4 to 12 weeks after a statin initiation or dose adjustments. So this is definitely more chronic outpatient management setting. So what is very high risk? It's defined as either multiple major ASCVD events on the left side of my slide here, or one major ASCVD event plus multiple high-risk conditions. And you'll notice a lot of our stroke patients unfortunately fall into this category. They have the stroke, and then they also have a lot of these comorbidities at baseline. Non-statin lowering therapies would include ezetimibe, bile acid sequestrants such as cholesterol or cholestyramine, and the new injectable PCSK9 inhibitors. And don't ask me any questions because we're not going to talk about that today. The reason being is I've shown the percentages of LDL therapy. You're going to say, wow, but they look really great. They work really well. Unfortunately, because those are still so new, the long-term safety outcomes have not been studied just yet, and it's very cost prohibitive, and I'm not really seeing them utilized just yet in clinical practice. So that really does shift even more in terms of our most recent guideline therapies towards ezetimibe for the fact that it's widely available, it's well tolerated, it's cost effective, and we're avoiding some of the really intolerable side effects from bile acid sequestrants, such as GI side effects, and the fact that it can sometimes exacerbate hypertriglyceridemia. And ezetimibe is dosed at 5 milligrams a day, and then it can be increased to 10 milligrams daily. So to drive this point home, patient MT is a 67-year-old male on the stroke service for a stroke. He was not a candidate for TPA. He presented outside of the time window, and his past medical history includes hypertension, diabetes, and hyperlipidemia. Admission medications include lisinopril, metformin, and atorvastatin. His LDL is 89. And what do we think, hinting off of this new category, would be the most appropriate for optimizing hyperlipidemia therapy? All right, so I'm going to kind of go through some of my thoughts on this. In terms of increasing that statin, we would definitely go for the combination of high-intensity statin and adding the non-statin therapy. So the things that I would think through on this is question number one, is the patient in the very high-risk category? Yes, he has a major stroke, and he gets the high-risk conditions, age greater than 65, hypertension, diabetes. Second, is his LDL greater than 70? Yes. Okay, so then I would think high-intensity statin, as well as initiating your non-statin therapy for added benefit. And then just to address triglycerides very briefly, because we do occasionally find patients that surprise us on our lipid panel. So for the management of triglycerides, 175 to 499, lifestyle modifications are recommended, or addressing it with statin therapy. As statin therapies do have LDL lowering properties as well as some triglyceride lowering properties. For those that are greater than 500 or documented as severe hypertriglyceridemia, it would be either a low-fat diet, adding a fibrate, or omega-3 fatty acids. If we do add a fibrate, fenofibrate would be preferred over gemfibrozil, as we often do have patients on statins already, and there's just less risk that's been documented of myopathy in combination with fenofibrate compared to gemfibrozil plus the statin. And of course, we would want to avoid or aim to eliminate any sort of offending agents that can potentially elevate triglycerides if that's an issue, and that's just for reference. And it is prudent to address two particularly challenging populations who we often see on stroke service. So the first one being age greater than 75 years. ASCVD is documented by defining this 10-year benefit, an ASCVD 10-year benefit of statin therapy. So as we see patients in the older population, we worry about whether they're going to really see the effects of that benefit. And whenever we're looking at that, there's been some guidance that says for a new initiated statin, moderate intensity statin may potentially be preferable, which is debated, very, very controversial. But if the patient is already on a high intensity statin, to leave them there if they're tolerating it, of course. The other additional sort of caveat is we can start considering adding ezetimibe to these patients if they're on a moderate intensity statin and their LDL already continues to remain greater than 70. The other patient population that we struggle with, sometimes these are the same two populations in one, are statin-associated muscle symptoms or leg weakness. So it's not documented or encouraged that we do routine monitoring or serial monitoring of this, but of course for a thorough workup it would be obtaining CK levels, liver transaminases, and hepatic panel. It's appropriate to re-challenge the patient at a lower dose or an alternate statin, or combine non-statin therapy. Again, so we're seeing this shift towards non-statin therapy combination in addition. If they fail their re-challenge, you can simply do non-statin therapy. And it is important to note that some evidence shows that coenzyme Q10 actually has no benefit with the leg weakness. Okay, so patient RM is an 82-year-old female. They have a stroke and their past medical history is only GERD. They're only on ranitidine 150 milligrams BID. Their LDL is 96. And I want to talk about maybe the most appropriate hyperlipidemia therapy. And I've identified most appropriate because, again, we're talking in gray areas. And you could probably argue your way in a couple different directions here. All right. I like the prompt responses. I'm going to try to rush to the finish line. So yeah, I chose A. Because this is a new initiation, I would do a high-intensity statin. So we're still, atorvastatin 40 is high intensity, but not at the max dose where we normally start stroke patients who might not be greater than that 75-year-old range, okay? And the patient, their LDL is still 96, so not less than the 70, which we kind of are seeing still that LDL target that lingers with us in some of our guideline recommendations. In terms of maybe not selecting B, because it's a new initiation, moderate intensity is not wrong given her age, but with the ASCVD risk, the stroke, and I would try high intensity still since we see that LDL is greater than 70. And then in terms of adding the non-statin therapy, definitely something to consider down the road. I just wouldn't jump to 2 medications right off the bat because this is a new start of statin, so we want to give her a chance for monotherapy. All right, so we're gonna shift gears here and approach some antiplatelets and anticoagulants. This is more so a sort of overarching theme and brief review. some new updates. So I like to answer the question of confusion between antiplatelet or anticoagulation with a brief reminder of matching the therapy to their stroke etiology. So again, this was kind of described a bit earlier today, but non-cardioembolic, or also known as thrombotic strokes, are the most common types of strokes. They're small artery lacunar strokes or the large artery extracranial and intracranial vessels. Those would be more of the antiplatelet focused benefit. Whereas cardioembolic, secondary to atrial fibrillation, will be more focusing on an anticoagulant. In terms of antiplatelet therapy, this is more so taking a management from an initial presentation, again, and think about that hyperacute setting through the continuum of care. That hyperacute setting guidance would suggest that we would start aspirin within 24 to 48 hours. And this ticagrelor recommendation comes from a study that just basically said we couldn't find superiority compared to aspirin, but it can be reasonable for those with contraindications. And then what I really wanted to focus on briefly here is this relatively new idea of dual antiplatelet therapy for select patients, and we're going to dig into that. And this comes from several larger randomized controlled trials that evaluated minor strokes, those being NIH scale less than 3 or ABCD score, which is a TIA score, of greater than or equal to 4. And so FASTER trial and the POINT trials on either ends of my slide here, they looked at evaluating 90 days of dual antiplatelet therapy. But unfortunately, both of them found an increased bleed risk. But the CHANCE trial, down the middle of my slides, found positive outcomes on decreasing stroke risk without increasing bleeding. And so a 2018 meta-analysis of this literature by Howe and colleagues did conclude that most of the benefit of dual antiplatelet therapy occurred within 10 days based on their survival curves. So we're finding it more so benefit in the acute setting compared to perhaps why these other trials didn't do so well looking at 90 days. And my takeaways for this are that for the appropriate selected patients, it would be an NIH scale of less than or equal to 3 or ABCD score greater than or equal to 4. Dr. Guzik's presentation was phenomenal when it comes to identifying minor strokes and really delineating what is considered to be minor, how there's gray area, how we need better scoring systems. But this is really just pulling it directly from the available evidence that we have until we're finding a bit more better characterization of these patients. That it must be started within 24 hours of symptom onset, again, secondary to the way it was studied in trial. And then I've also provided a potential strategy here, because a lot of times we're thinking, okay, well, what dosing are we doing and for how long? It would be loading with 300 milligrams of clopidogrel and 162 milligrams of aspirin times 1, then daily clopidogrel 75 milligrams with aspirin 81 milligrams daily for 7 to 21 days, at which point after that would drift into just a single antiplatelet regimen. So in terms of antiplatelets, it's very similar to the vague or soft language that we see in the blood pressure management. Selection of antiplatelet therapy is also determined largely by logistical considerations, cost, and tolerance. And I've provided some available doses as well as strategy options, but again, choice of those agents is really left up to clinical practice. And then in terms of another subset of patients that may benefit from dual antiplatelet therapy, it's just listed that those that are seen with ICA stenosis, 70 to 99% can do aspirin and clopidogrel for 90 days, begun within 30 days of the stroke or TIA. But really what I wanted to focus on in this slide and the context of this is those that present with aspirin failure. It's really important to understand that evidence is still lacking for an optimal direction on managing those patients who experience a stroke on aspirin. And the dose may be considered to be increased or maybe switching to a different agent, but neither of those, unfortunately, is really well defined for us in studies at this time. In the interest of time, so this slide is mostly available for reference, but I did want to include several pearls, and that would include aspirin giving us the option of creativity whenever we need to administer via different medication routes. So sometimes it does come down to the common sense thing. Enteric coated cannot be crushed. We do have a chew form for needing to get it down a tube for administration, or suppository if need be, and the patient doesn't even have enteral access yet. The other thing to think about, one for clopidogrel, would be that it is, out of the P2Y12 inhibitors, the most studied. So it leaves us feeling the most comfortable at most times. However, there is some growing concerns or theories about whenever you hear whether the patient may be a non-responder. And that would potentially mean that it would be utilizing some lab values, platelet reactivity, but unfortunately a lot of that literature comes from the cardiology population and the PCI intervention type of population. So it's difficult to extrapolate, looking at what threshold that matters, and then matching that to a clinical outcome. It's still kind of yet to be debated in clinical practice. And then the other thing, the main takeaway with ticagrelor is that, surprisingly, and often sometimes missed, one of the main limiting intolerances of this is dyspnea or shortness of breath. It can occur in up to 14% of patients, and is recommended to avoid or definitely use caution in patients, again, with airway disease. Okay, so drifting into some anticoagulant therapy. So for those of cardioembolic etiology, again, anticoagulation is considered for stroke prevention, and we do that most commonly within 14 days after stroke onset. Newer evidence that I wanted to bring to you guys is that we've actually shifted in guideline and recommended practice to favor direct oral anticoagulants over warfarin therapy. But again, this comes down to making sure that it's a patient and caregiver preference, that we're looking at cost considerations and anticipated medication adherence versus compliance with INR testing. Interesting and provided for reference is a newly validated tool from the 2018 atrial fibrillation guidelines. So again, trying to get you guys just some new things to get in front of you. But it's known as the same TTR score, which I thought was really helpful in making some of these tricky decisions. So of course we would complete this score after the CHADS-VASc and the HAS-BLED. The CHADS-VASc, looking at the risk for stroke, and the HAS-BLED, looking at the risk for bleed, can help us stratify a risk versus benefit for anticoagulation. Once we decide, yes, we want to anticoagulate, the same TTR score can help us when considering warfarin therapy to maybe predict whether they would be a good candidate and whether they would stay within their time and therapeutic range. That time and therapeutic range, we do have a goal of around 65% that's been documented for some of our guideline recommendations. And achieving a score of 0 to 2 would potentially achieve, would say that the patient is likely to achieve that good time in their INR range. A score of greater than 2 would mean that the patient is less likely. So the patient would, again, be more urged to direct oral anticoagulant therapy, or if they are a true warfarin candidate and warfarin is definitely the medication that we're choosing, they need to have more frequent INR follow-ups, more education and counseling, and just overall closer interval follow-ups. Okay, so I do have a case, but we're basically evaluating that same TTR score. This is a true case. I'm just going to talk through it in the interest of time. But basically, it's just describing that this patient truly was a same TTR score of 3. This matches against the fact that this was a validated score, and a score of 3 would render the patient not a very good candidate for warfarin therapy. Unfortunately, one of the situations that we come to is that the patient was an aortic valve replacement, rendering them not an appropriate candidate for DOAC therapy at this current time per FDA approved recommendations. So this patient just would have benefited from, again, more frequent monitoring, INR checks, and things of that nature. So in terms of a takeaway of anticoagulation, for direct oral anticoagulants, the selection of drug and doses is definitely based on comorbidities, compliance, and organ function. I could spend an entire topic just on that. And the one takeaway point that I did want to really stress is that cost barriers that often limit us for DOACs shouldn't be an end-all be-all. It is important to investigate patients that would be candidates for either copay assistance cards, transitional care programs, and a lot of community resources that have been recently a lot more robust to be able to get these patients the preferred therapy that they need. And then ongoing assessment of drug interactions, compliance, and dosing is very appropriate in the setting. Just because we think that it doesn't require an INR check, that doesn't mean that it doesn't need to be monitored closely and taken into a lot of consideration. For warfarin therapy, again, we're just needing to identify those optimal candidates to achieve the time and therapeutic range, and as well as those that are high risk and they need closer follow-up. And of course, ongoing nutritional status and drug interactions are definitely main takeaways. And so to wrap all of that broad stuff up, I wanted to kind of summarize and really bring my heart to you guys as to what I thought was maybe beneficial in looking at medication for stroke patients across the entire range. So it's going to vary, again, depending on the time course and the care setting of a stroke patient. That's why we're using medications that look different in the ICU versus the floor versus an outpatient setting. It's going to be a balance of that available evidence and pharmacokinetic considerations. Secondary prevention for hypertension will be more aggressive as the patient progresses out of that acute phase. Secondary prevention for hyperlipidemia can now include careful attention to not only maximally tolerated statin therapy, but also considering addition of non-statin LDL lowering therapies. New evidence for that antiplatelet therapy would be further stratified by stroke severity to identify potential candidates for that dual antiplatelet therapy. And then trends of anticoagulation favored the direct oral anticoagulants now, with emphasis on optimizing compliance and enhanced scoring tools that we have available for improving safety and efficacy. Really just identifying appropriate candidates for these different sort of gray area scenarios. So with that being said, I will definitely be happy to take any questions. Or let you guys go. Let's see. 3 for 9. Yes, thanks guys.